Welcome to the Data First Podcast, the podcast where we dive deep into cutting-edge research on physical, mental, and spiritual health. From psychedelics and new medical techniques to nutrition and religion, we explore how these topics impact well-being and resilience. Join us as we break down and analyze important research studies driving decision-making and optimal performance in holistic health.
Chris has released a book since then called Operator Syndrome. I've done a book review through the Special Operations Association of America on LinkedIn. You can read the review. It's an awesome book. What he's calling Operator Syndrome.
I like it way better than PTSD. I mean, no, are associated with. I'm not like direct no. Direct no, I know a lot of guys personally. There's a higher rate of suicide in the special operations community.
The anecdotal estimates suggest 85% of SOF operators experience TBI from training alone. How much does TBI play into this? Do you know anybody that doesn't have a TBI? Any of your friends from PJs or?
I wouldn't say it's possible. What's your tolerance? Did you have a lot of TBIs growing up?
I've tried to stay tired in the cold plunge, dude. It doesn't work. No. It's impossible.
Nobody's sleeping in the cold plunge.
All right. Welcome back to the Data First Podcast. Chris Klaftenegger and Ryan Ziegler. Today we are talking about a continuing to develop syndrome, operator syndrome. I think we've both kind of dabbled in this realm in our patient care experience and our own experiences. And I know a lot of guys that have been dealing with operator syndrome. We're going over a study by Chris Frueh. This was done or published back in 2020. So it's been 4 years since this was published. Chris has released a book since then called Operator Syndrome. I've done a book review through the Special Operations Association of America on LinkedIn. You can read the review. It's an awesome book. It basically takes a lot of the stuff outlined in this study and it dives deeper into each aspect of it. And so thank you, Chris, and everybody else that took the time and effort, a lot of effort to write this. How many do you know quite a few guys in this realm that have dealt with what we're calling or what he's calling operator syndrome?
Yeah, the new one. I like it way better than PTSD. Actually, I know. I think between us both, we know probably thousands of people that are associated with. I'm not like direct no. Direct no, I know a lot of guys personally that have struggled with this, have found different treatment modalities that are out there outside of the VA, outside of traditional means that we could talk about, that including myself, that have been life-changing. So I think it's definitely mention worthy. But yeah, definitely. I think it's a real thing. I like that the constellation, I like that they're taking the whole picture into account. It's not just like PTSD, depression, we're going to treat this A to Z. We're going to treat this A to Z. And, most times that's with meds of some sort. So pills. There's a reason that there's a higher rate of suicide in the special operations community than there is. And I'm not discounting anything by saying that. I'm just saying this, the statistics are there. It's a higher rate with special operations veterans that have gotten out, been successful in retirement or some form of, reasonable amount of support, and then just go the wrong way, and it's really frustrating to watch. I lost a couple guys in the last month, different, not associated, different career fields, but out of the blue, happy family, kids, job, everything's good. And then dude's gone.
I think within this community, we're really good at putting on the armor that everyone else sees. And I don't want to say faking it, but, not showing weakness, not showing your fear, I know overseas, like the last thing I wanted to project is fear, though. How could you not have some amount of fear going into some of the situations that we're put into, and you just turn that part of your brain off, or you try to at least let the other, oftentimes it's anger that comes out, and that's how that's accepted within the community is to,
it's promoted. Anger is a gift. It's in, anger keeps you warm. Like all the sayings and stuff, like when you're pushing through stuff, anger is what, and I 100% was in. If you would ask me back then and up until this past year, like I would have said, yeah, absolutely. Yes. Anger. You have to have it in order to get through a lot of the stuff that I come into contact with in life, just to push through. I'm going to run through it. I would say there's another way. That's actually way more healthy, way more centered. And you could still be aggressive. You could still be who you are. You could still have a spine. You could still, push through stuff, but you don't have to, anger isn't the answer. It's actually destructive. And I think guys are good, myself included, until you're not. Like you could do it until you can't anymore and you're overwhelmed. And then that's a fight that I don't think, the data is showing it. That's a fight we're not ready for because the guys are losing. Families are losing. children are losing their dads and their mom. Like it's fucking, excuse the F-bombs, but it's frustrating, especially knowing that there is a way there are treatment modalities out there that we all have access to. The word hasn't reached those guys. And it's frustrating.
Yeah, no doubt. So in the introduction, I'll read off some of the key points that I've highlighted. So approximately 8% of all veterans from recent wars in Iraq and Afghanistan suffer from PTSD, post-traumatic stress disorder, and other forms of psychiatric illness stemming from deployment experiences. I don't think anybody's going to contest that. However, there is a group of military personnel and veterans who, because of their unique and extreme nature of their military service, are likely not well served by current programs or traditional models of care, and that's the special operations community. So he lays it out here where there's clinical trials that have shown effectiveness of psychotherapy for PTSD in combat veterans. What he's saying is, in the study, what they're noting is that within this population, the special operations forces, the traditional models aren't working as well. And so there's no citation here attached to that. That's, from what I can see, that's their assessment. And from
based
talking
on the
to
50,
guys,
based on the 50 that they talked to, right?
Yes. Yeah. And it's like, it's any study. You're going to get a population base, like a number to treat or a number to study there. And it says about 50 guys that they talk to and their wives and girlfriends. And they talk to some psychiatrists and psychologists and docs at those special operations units. That's where they got all this data from. We'll get into that. But in terms of what they're noting, and it's their statement, is that these traditional forms of care that are available are not serving this soft community as in the same way that it serves, let's say, an 11 Bravo or a 13 Fox or whatever your MOS was, or your AFSC.
That's it's kind of an interesting finding. I mean, I think anecdotally, I understand why, and it's not to downplay it, because I mean, the 11 Bravos are the ones that are kicking doors in Iraq and Afghanistan. They're going house to house. They're getting blown up the same as all of us, There's no distinction, I don't think. I think out the top of my head, just thinking about the differences between how you become, a special operations guy, girl, and how you become 11 Bravo. It's the length of training and the stress inoculation and the ability that is created out of that, that pipeline or assembly line in creating a special operator of, and also the inherent resilience that has to be in those people out of the gate to make it, to even volunteer and then go through everything they have to go through to become, the Green Beret, the PJ, the SEAL, the Ranger, the whatever, and then to continue operating in that environment. And being around all of those other high performing type operators, I think that might be a little bit of the difference. I just want to I don't want to downplay contributions here, because we're all cogs in the wheel. We all fight. We were all in the fight. Everybody had jobs to do, right? So you go through selection. So you suck in the beginning so that you can get different missions and some cool, better gear, be around those type people that are driven to that level of excellence. Not that 11 Bravo or the Corpsmen or the Marines or, the ground force, not that there's any, their contribution was any more or less than the special operator. We just took a right and they kept going straight, and then we went on our path. But the outcome that we're talking about is the interesting part. Is it's not about while you're in, it's the ripple effect afterwards that resonates throughout their lives. And at some point, a lot of us are reaching that point of like that breaking point, and it's like, why? What is that? What is the problem here? And then also, what are the solutions?
Yeah, exposure. So if you think about it, just one of the exposures that is a constant in the special operations community is going to be, let's say, airborne or free fall. Free fall, it's not as constant, but I don't know any Green Beret that's not airborne qualified and that doesn't jump during their career once a quarter, unless they have some kind of ailment, getting 4 jumps a year. You look at like the G forces and hitting the ground. I don't know anybody that's ever done a static line jump that hasn't had at least one shitty fall. One shitty landing where you just kind of lay there for a second, check your fingers and toes, and make sure everything, all systems check, as you're before you start packing your parachute up to walk. Hopefully you're close to the rally point, and then figuring it out as you go. And then Yeah, I had one
An
guy
egg?
walk up,
Go ahead.
I had one guy walk off the DZ, and it's probably 30 minutes later, he had anoscoria, which is one pupil was just blown out, dilated.
Oh, shit.
I mean, he suffered a pretty
Yeah.
significant. We ended up in the ER. They did the scans, and he didn't have any
Yeah.
bleeds or anything. Okay, you did the scans initially. What happened to that guy? Right? Like, did
Yeah.
he
What was
get
the
any
follow-up?
follow
Yeah.
up? Where's the follow up? And he went right back into training. I think it was, if I remember, maybe he got put on profile for a little bit, but still, in terms of where's the follow up 5-10 years down the road, or when he gets out, are there appropriate surveillance of that kind of thing? I mean, he's going to put TBI hopefully on his paperwork when he gets out, when he gets to the VA, or with his civilian provider.
That's a hard one to get in for. I think it's been talked about. I even think it's been studied, and I think the 82nd right now is doing a study on TBI, and they're including jumping, exit, and landing in that with blast injury and all the things that you get exposed to with concussion. But I was the opening too. I had some of the hardest openings, rocked, and I don't even know where I am until I'm probably halfway down, and that's just out of the plane. And nobody talks about that. Everybody talks about the landing on the ground. Like some of those exits were like, wow, you get like your chute opens immediately out of the plane. You're like, just get ragdolled. And then you're trying to, figure out what the hell, which way's up, down, where you're going to land. Like, I definitely had my bell rung a couple of times and my neck fused because of it, because of those type thing. I mean, same for free fall. You get a rigger that packs your chute, or you pack your own chute, and it opens. It didn't stow the slider correctly. You get a line dump, and you get rocked in that as well with a heavy combat load. Like you'll pull 6, 7, 8 G's on that opening, and that's significant stuff. And nobody's tracking any of that right now. Not across the force.
Right.
It's been studied, but it's not across the force.
That's just one common exposure that this particular group has. Not to say that, 82nd, I mean, dude, I was never part of one of those mass attacks, but I remember watching it and thinking, thank God I am not part of that. Because while it's, it's an awesome thing to watch, and it's super impressive that we can, our commanders can coordinate that, and guys are on it, and, they can do it for what it is, a safe manner. They have an expected number of casualties from any one of those training events. It's still pretty friggin' impressive that as many guys walk off the DZ as they do when they do that, and all the jump masters and everybody else, all the coordination of effort in that, and it's super impressive. But they have the same exposure as a soft guy, and maybe we're missing some of those that have these symptoms, especially if they've been in for 10 years and they've been a first sergeant and they've had the chronic mental stress. They've had the physical stress. They've had the TBIs from the jumps. It's not to say that they don't have this operator syndrome, I don't think. But as a whole, what they identified here is that this is something that's pretty prevalent within the community, the soft community. So I don't think it's exclusionary. By naming it operator syndrome, it seemingly excludes some populations. I've talked to a lot of firefighters and police officers that seem to be going through a very similar situation. That their sleep's all jacked up. They go from nights to days. Firefighters obviously waking up all the time. Their physical requirements are super heavy. They're on guard a lot because of the nature of their job. So these kinds of things. So I think this could probably translate to other outside of the military as well. Predominantly what I've seen is it gets labeled as PTSD, and this is not a diagnosis yet. I think that's something else that's key for our listeners and viewers to understand, is this is not a diagnosis. So when you go into your doc and you say, I think I have operator syndrome, first off, they probably don't even know what that is. It's not taught in school. It's not something it's not common knowledge yet. So until as the ball continues to roll on this, more and more people will know what it is, and then a treatment approach needs to be solidified to understand how we screen for it, how we identify it, and then what to do about it. Which probably aligns the most, from what I can tell, with TBI clinics and the way that the military and the VA and everybody's setting up their TBI clinics, which is pretty extensive. It's getting into that world that's the most important, I think, though. Getting at least a diagnosis that gets you into that treatment protocol that seems to be most aligned with operator syndrome. but we'll keep going here.
Yeah.
So they also note that many soft operators now face a cascade of medical, emotional, and social problems that are not adequately captured by psychiatric diagnoses of depression or PTSD as they transition to civilian life. What he states here is we describe the unique constellation of medical and behavioral healthcare needs of this population. So I think that lays out very well what the study really talks about. This is not just psychological. This is not just physical. This is a combination. And they lay out that basically the needs, things that need to be covered when approaching this topic. So what they did was, under the methods section, consulted with over 50 SOF operators from the Army, Navy, Marines, and intelligence units who provided verbal, informed consent to be represented in this descriptive study. Involved thousands of hours of conversations with these operators and their spouses and girlfriends about their life experiences, their lives experiences, medical and psychological health, and current functioning. And then also they had conversations with individuals closely associated with the SOF community, including military officers, number greater than 5, and leaders throughout the ranks, psychologists greater than 5, psychiatrists, physicians, speech therapists, and physical therapists. They talk to a number of different people in these different medical specialties, as well as spouses, people close to the SOF operator that have an outside view of how things have changed over the time or how they're seeing them now. One thing that I would say about the methods section is they said consulted with over 50. Like, why not put in the actual number? That's one thing. And so, that's one thing that I was like, oh, it's kind of weird they didn't do that. I don't know that it changes particularly any of the outcomes or my view of what in their discussion or anything, but I was questioning why put over 50 instead of 51 or 50.
Was it 51 or was it
100 or some number over? So that's just one thing that I noticed from this. And then
probably 50, because I think maybe they're referring to what it may look, what might be happening, or what they may have kind of intended is in there. They talked to 50 operators, but they talked to all of their family, like a lot of their families, their girlfriends, their wives, their
I see.
Whatever, what I mean? So that all of that equals more than 50, but 50 operators, maybe. They don't specify in there, but it's possible.
Yeah. So then they jump right into results, a point which is kind of somewhat into the, it's important to understand before reading the results, but research already points to heightened challenges of veterans with comorbid symptoms. So things that can make things worse, that they already have, and the increased risk of developing additional combat-related disorders if one is present. So I had a conversation with a psychologist when I was down in El Paso at the Warrior Transition Battalion, and what she was saying is one of the reasons that they screen for other psychiatric conditions prior to going into SF or name your SOF community is because you're more likely, if you're already slightly depressed, once you have more trauma, it's going to accentuate that much more than somebody that doesn't already, if that makes sense.
Well, it's going to exacerbate.
Yeah, very much so.
It's like a synergy or catalyst. Yeah.
Yeah. So, and I don't know anybody. I have yet to find one person in the SOF community that didn't have some kind of hardship growing up.
Yeah, I mean, I think
maybe that's just everybody in the world. I don't know.
I think it largely. I think it is. I think the hardest thing you've been through is the hardest thing you've been through. There's no mine's worse than yours. Like when we're talking about within the human condition.
Yeah.
So I think from that perspective, and just the age group that fought the most recent war, and I'm sure if you do that for the same career fields and you look at that their childhoods and stuff like that, they grew up in an era parenting and children were not as understood as they are now. And I think, is that good or bad? I don't know. I think it's bad to understand too much and pamper and to everybody gets a trophy. We've seen kind of what happens with that.
Yeah.
Culturally. And, I grew up in the 70s, and I got paddled at school. I got paddled by my teachers. I got whipped at home. It was like different, kids were seen and not heard. It was a different expectation as far as children. Now they're very in the mix. They're talking to adults. They're very well adjusted. They have access to so much information through the internet and all that stuff. We had to use the Dewey Decimal System and everybody had the Encyclopedia Britannica in their houses. Like that's how we figured stuff out.
I got a technical issue here.
Yeah.
I'll try to cut you off. I'm going to plug in. All right. So we're talking about the kind of the difference in childhood experience and then how that potentially relates to worsening of outcomes related to combat experiences and just prior traumas or prior mental health conditions and things like this, and why the special operations community pays so close attention to that. I don't know. How many psychological evaluations did you undergo in the PJ pipeline?
None in the PJs. I went through in the Navy. The only real psychological survey I went through, it was pretty extensive, was when I was at Buds. I joined the Navy and was going to be a SEAL, just like a lot of other guys. Ended up dropping out right before Hell Week, and then quickly realized that was a huge mistake, and was lucky enough to cross back over into recon and get to serve with those guys. But I did take one there, and it was, do you like yellow flowers? And that kind of stuff. Would you kill your mom? Or it's nothing direct, but it was like a bunch of random questions about, I have no idea. But that's really the only official psychological test that I took.
I think in the Q course I was in the Q course as in selection. It was like a whole week, like the back half of the day, if I remember. It's all kind of a blur because we weren't really sleeping very much, and they got us real tired. And then over the course of a week or two, and then we take these like written exams. And it's a similar thing. I think one of the tests is like 400 questions, dude. That was brutal.
A lot.
Trying to not fall asleep. Yeah, and it's asking you about, I don't know, like, do you like lighting fires? Something about killing animals. Whatever that is.
I think that's the same test. It's just long as fuck. So you end up, I think it's like you end up not being able to remember what you said about everything else. So you can't really cheat that test.
Right.
You just have to do I like yellow flowers? Sure. Do I like red flowers? Yeah. Do I like red better than yellow? No. I don't care. I think eventually you're just like, I don't fucking care, man. And that's where they want you. But I have to take that back. I did do an evaluation at INDOC. Now that I'm thinking back, they had a psychologist come in for a week and observe us, talk to us. And I think I remember doing it the same. I don't know. It was probably the same test during that as well. Yeah.
So they survey for it. It's not like they're not taking that into account. So they're seeing if there's signs. I'm not a psychologist or a psychiatrist, so I don't know. But it is something that's already there. So that's hopefully worked out before we get started. But potentially things can get worse but in this group of soft, operators, you have a group that's been screened already. So hopefully minimize the risk of having issues, comorbid symptoms already before you even get started. So that's minimized. The next thing that they talk about here is traumatic brain injury effects. Of course, blast wave versus direct impact. The anecdotal estimates suggest 85% of SOF operators experience TBI from training alone. So if TBI is related to this thing, this is anecdotal, but 85% of SOF operators experience TBI just in training. That's not even in combat. So if you just assume that basically everybody has had a TBI, how much does TBI play into this with dysregulation of hormones and everything else that goes along with it? And two types of long-term brain injury other than concussions that have been posited in the recent years. And this is chronic traumatic encephalopathy, CTE. We saw that with the NFL. They did a big study on that. Now, from impact trauma, hence it's related to impact, versus interfaced astroglial scarring caused by the shearing forces of blast wave exposure. And I wrote, so astroglia, what they do, this is a cell type, a neuron or a nerve cell type that helps support metabolic activities. So basically helping the cell stay alive and like that. They recycle neurotransmitters. So that would be things like serotonin, which if you take an SSRI, serotonin selective reuptake inhibitor. So if they're recycling neurotransmitters, obviously the health of those astroglia are very important. They regulate blood flow, obviously very important. Astrogliosis is the scar tissue to isolate damage. So this is what happens. So that shearing force occurs, and then we have this, there's a scarring, just like if you cut your skin, you're going to have a scar there, which is anytime there's a scar, it worsens basically how well that tissue works. So scar tissue on the skin, if somebody has a lot of scar tissue on their arm, let's say from a severe burn, that skin is not stretchy. It doesn't regulate heat as well. All these kinds of issues occur with the skin. Just imagine with the nerve, it's not going to work as well. And since nerves are associated to cognitive ability, whether it's memory, whether it's emotion, those kinds of things, it's going to be dysregulated and just all out of whack. And then they note here the centrality of TBI will become apparent as we discuss further these features of this syndrome. So what they've noticed is that TBI is like this underlying chronic thing, or not so much chronic, but it's basically TBI. Everybody's got a TBI. So this is kind of the underlying issue that all these other things seem to be stacked on top of, along with the high allostatic load over time.
Yeah.
And then they get into this. I mean, do you know anybody that doesn't have a TBI? Any of your friends from PJs or?
I mean, I wouldn't say it's possible. I mean, it just, everybody jumps, everybody has bad openings, everybody has bad landings, everybody's been through blasts, everybody's been through training, everybody's done breaching, everybody's been in closed spaces with the weapons system.
Yeah.
Like we've all felt it. Like and then it's the same thing is like, what's your tolerance? Did you have a lot of TBIs growing up? You know, if you like, were you an active kid? Probably all of us were. So, I mean, it's like, and they know through football, it's not the big one. It's all those micro hits from childhood all the way up through college, all the way up through. It's really about the longevity and how many hits you took, not about like that big punishing hook. All that hit, although that can create significant damage I'm sure with all the scar tissue, because as you said, it becomes less elastic, you know, and those big hits have huge deficits. And that's where I think in a lot of cases people notice, you know, the big changes, you know, as you get older, you know, the higher mileage operators and athletes or whatever. So I'd say no. I mean, it's not possible if you served at all and you made it through selection and you've been on a deployment or two and, you know, any of that, like you absolutely have TBI. I mean, without a doubt.
Yeah.
There's some level, you know?
Yeah. I just got back from the ophthalmologist yesterday, and I've been diagnosed. They tried to diagnose me with glaucoma and this other stuff. And then eventually yesterday, sitting down with the doc, just describing my history, all the Carl Gustavs I've shot, and different things. Mm-hmm. My right optic nerve, part of it is just showed everything else on the eye, like in their little scanner thing, shows up with this nice bright red or yellow, all this stuff. On one segment, it's just this like gray looking space. And he's like, well, that's where your optic nerve is dead. It's not working.
Shit.
Yeah. And
it's like,
he's like, yeah. And there can be congenital causes for this. You can, if you have, there's open angle, closed angle glaucoma, there's different things that can cause this. And after our discussion, he's like, it actually makes a lot of sense that this is TBI caused versus something else. Your pressures are good, all this other stuff. It doesn't make any sense. So then my next question was, well, how do we fix it?
Yeah.
Like you're telling me part of my eyes, I've been told I can't see in a particular part of my vision, blah, blah, blah. Like, okay, so then what's next? And his answer is, well, I've never heard of anybody fixing that. I'm like, well, my foot didn't work for a long time and that grew back. And then he described that the type of nerve, the optic nerve is more like it's more like a spinal cord injury than a peripheral nerve injury, the way it's set up. So recovery it's just different. So I don't know.
Like I said here, the optic nerve is part of your cranial nerve system, right?
Yeah.
That's like, that's a direct line from the source.
Yeah.
It's not an ancillary line. Yeah.
No, so I guess it's different. I'm not a ophthalmologist, you know. So I gave him the challenge. I said, well, if you want to nerd out tonight and see if we can't figure out a way to get this thing back and, you know, improve this, you know, please, I would very much appreciate you taking an hour and doing a little bit of, you know, some literature research on this kind of thing.
Like with, like my mom had radiation, and the radiation damaged part of her lung.
Okay.
And she has I forget anyway, but it'll never recover. Like the lung tissue's damaged in that area, and she's on oxygen and she's doing her thing. And I'm like, well, I mean, it stands to reason for me that if you have a damaged part of your lung or another organ, that you can do things to strengthen the rest of that, your lungs or that nerve. And the same thing, like if there are vitamins, if there's some sort of supplement or peptides or something where you can enhance nervous system part, you know, that works around that dead portion. Is there something specific to the optic nerve that you can take or that you can do exercises up, down, all the way, whatever it is, you know, is there something where you could increase the strength of everything around it to account for that.
Yeah. Or at least
rather
protect
than that,
it.
Or protect it, prevent further damage, whatever, but it's got to be, in my mind anyway.
Maybe just don't shoot so many Carl Gustavs.
That'd be the first one. I mean, stem cell, what about stem cell?
I don't know.
Is that something?
Great point. Actually, I'm gonna dive into that a little bit and see if maybe that's something that could be of benefit. That's a good one. Anyhow, a little off topic, but so in terms of TBI and catching these things, that was caught through the TBI clinic initially in Long Beach. I went to the VA there, and they have an amazing program down there. And they didn't necessarily know what it was at the time, and it was so early after. And I had so much other shit going on that was the last. That was the last of my worries. I'm like, they were giving me a drop to reduce I think I had some increased IOP, intraocular pressure, and different things. They're like, well, do this drop, and it says change your eye color and blah blah blah. And they were. I think my IOP was elevated, so they're trying to protect my eyes. I said, well, let's just pump the brakes here and see if we give it. See if this thing is stable. If it's stable and not progressive, then this is likely just a traumatic event. It's not. This is not a continuously getting worse thing, so I don't need the drops. And ended up I guess I got lucky. It ended up working in my benefit to not initiate, and helped identify that wasn't the issue. But yeah, so the TBI thing, there's so many different things. I don't know how many conventional guys shoot Carl Gustavs, at least as many as we did. Probably not too many. I know that they're out there and they do have Gustav teams and stuff, but they would be at a higher risk based on what I'm reading for this kind of thing, depending on what else they have going on in their life, at least for the TBI part.
I think it's kind of like, because I've been, I'm in the VA and, have the rating and everything, but, and the asks on things, is like, you say like, I have a TBI, I think I probably do. And they're like, well, what was the event? Choose your poison. They could probably give you literally 100 events that could cause. I've been knocked out, by a static line landing, woke up, very quickly. I wasn't out very long enough to like pull my riser because it's dragging me across the drop zone. But for a minute I was gone, and then I'm back, and I'm like, okay, well, that's an event. I did like countless events because everything that we're doing is very high energy, very high velocity. And it's like, how many events didn't give me the potential TBI? I don't know. Did I test and validate and do all that stuff? No, because the culture is I'm going to get back on the plane and jump again. I got my bell rung, not hurt. Like, poof, I'll feel that tomorrow. You're like, okay, good, get the shoot and go again. Okay, that's what we're doing.
Yeah.
By the end of the day, you're like, I got a fucking splitting headache, and who knows? Because nobody's watching for it, because we just didn't know at that point. Kind of like the childhood thing. It's like we didn't know about kids back then, and really how developed and how exposure to stuff is really good for their development. It's like you didn't know back then. So same thing. We didn't know that we were getting rocked, and that was actually going to be detrimental later.
That's a really good. Through. There's no, I've never been asked, like, it always is like, what was the event? Like, if somebody's an artilleryman, they've had a lot of, even if it's small, but like small concussive exposure. And I don't know that there's a diagnosis code for multiple micro TBIs. Yet. Yeah.
It's like, what was the big one? It's like, well, I didn't have a big one. I had a shit ton of small ones though.
Yeah. If you're a breacher.
Yeah. Yeah. That's why you're at the back of the stack, because you can get your wits about you and go, I don't know, man. It's blowing out of like the old school way of blowing out of a OP. Like if you're doing black gold or whatever, and you set claymores.
Yep.
And you have you're getting assaulted from one way, and you flak, blow claymores. They're right there.
Right.
It's pointy end toward the bad guy, but it's coming back too. That blast is coming back at you, and it's a block of C4. Like that's probably some of the hardest hits I've taken is in that, like double clacking a claymores to blow out of an OP to start into a live fire event. You're like, the first part of it, you're like cross-eyed going, trying to hit targets, useless. It's crazy. And then that's not even, we didn't use ear pro either back then. Just wasn't a thing. It's like, I got to be able to hear what's going on.
Yeah.
Before we initiate, and then after we initiate, and you're like, you can't, everything's muted. You're like, is this thing on, afterwards.
Yeah, it's a balance between protection and, I guess, protection, being aware.
Yeah. There's a balance in it. And technology caught up in the Air Force. that was all in the Navy and with the Marines. But in the Air Force, it's much better. Like we have peltors and things where you can actually hear.
Right.
You can hear like the leaves crunching under your feet and stuff. You're like, I'm being really loud. You take it off and you're like, oh, no, it's really quiet. Never mind. You as you progress. So, I mean, I think, I had the luxury or whatever it is of kind of being in the middle between that transition, along with human performance optimization programs and all that stuff. It wasn't around back before that. It's like you train and you do it and you meet the standard, or you excel, you beat the standard, and don't be the guy like that. So you just ran and lifted and you did everything, swam and finned and did everything you could, shot, did your medicine, did your job. I just do it all the time.
Yeah,
it wasn't ever like, there's no method to the madness. It was just like, do it all, go.
Yeah, you run your 5 miles in your combat boots.
Yeah.
that's good for you. Yeah.
No, I ran anecdotal. I mean, it's just a whatever story, but I ran my first, we did you had to do a bunch of PT tests in boot camp in Navy to like keep qualifying to go to BUDS, to go to the SEALs. And so I ran all of those, like you PT and PT gear, but you'd go to these SEAL motivator like PT sessions. And I did it all except for the pool stuff. All of those PT tests in like old school Navy, blue shirt, white shirt, the jeans that are tight at the top and bell bottoms at the bottom with boondockers that are like, they're steel-toed work boots. It's not a fucking running shoe, bro. It's not even a combat boot. It's literally to stand on the flight deck with steel toe. And like, that's what we ran those things in. We're all like, clunk, clunk, like it was goofy as fuck. It was super goofy. But you pass because you have to. But yeah, it's funny. Yeah, that's not great for you either. Flat shoes, no support.
Yeah.
With like literally a steel shank and a steel toe. That's not what you're supposed to be running it. Not at
all. I mean, if you need to be, it's one of those things we train so that we can, right?
Yeah.
You train so you can, but to beat your body up that hard. Luckily, a lot of that stuff's old school mentalities kind of gone by the wayside, in terms of breaking guys over some bullshit like that.
It's about retention. And they're seeing that like that stuff then equals injury. And it's like, we're going to lose game days.
Yeah.
Because we're being idiots on the front end of this. Put them in fucking running shoes.
Yeah.
And prevent this injury down the road, man.
There's something to mental toughness though. Like what they did with that, they continued to develop the mental toughness needed to be able to run in fucking steel shoes.
Yeah.
Like,
go.
So there's a mental toughness aspect that some would argue is kind of diminishing within the ranks. But I think there's culturally
balance. There's a balance there somewhere where it's like, okay, we're not really breaking guys, but we're also, developing that, like, no matter what, we're going to get through this. Like I'm going to, no matter what, like, it doesn't matter what I'm wearing, doesn't matter what the weather is. It's like, I'm doing it,
Right. Yeah. So there's got to be maybe once a week, once every 2 weeks. I don't know. I'm just talking, but to do those kinds of events that are the mental toughness events, it should not be to develop somebody physically running in steel shoes.
Yeah. It's like, I'm going to take you off your game. It's like, you ran a 6 minute in shoes. Let's see what you can do with steel toe boots. Go. Cause you never know, okay. Roger that.
So the next thing, they broke it down as traumatic brain injury is kind of the base that becomes apparent, and the centrality of TBI. The next thing they bring up, and I think they did a good job in how they ordered these also and kind of triaged them in a sense of, I don't want to call it importance, but I don't even know how to describe it, but, how it affects things and how severely it affects. The next is the endocrine dysfunction. And this is gaining some groundswell in the community as well as, at multiple levels within the government. But so TBI has a powerful dysregulating effect on the endocrine system, and particularly TBI secondary to blast wave exposure. So there's evidence that shows that once you have TBI, it can create dysregulation in the endocrine system. That includes like your testosterone and different neurochemicals that are neurotransmitters. And it's believed that overactivity of the hypothalamic pituitary adrenal axis, that's the essentially hypothalamus sends some signals to pituitary, sends it down. Well, it sends it to your adrenal cortex, but also to your gonads and other parts of the body to signal to the body to make different hormones and things that then make us feel a certain kind of way, right? Like if you're low in testosterone, there's a whole bunch of, symptoms that one will have. And that's, and they mention it here, through acute or chronic stress. So regulation of the brain and the adrenal gland increases secretion of cortisol and norepinephrine, leading to insomnia and sleep disruption. So it's not just, being able to get strong and things like this, but it actually has an effect on sleep and for a lot of guys, insomnia. I know a lot of dudes, they especially earlier in the war, I got a lot of old retired buddies that they're all on Ambien.
Yeah.
Chronically. They've been taking Ambien for like 10 years because they can't sleep without it, and
the VA's like, can't sleep? Here, take this.
Yeah. Well, I think a lot of providers, you hit a certain, it's not just the VA, it's just kind of the
Western medicine, period.
Yeah, you hit a certain wall with guys, and he thinks I'm giving a thumbs up. It automatically does that. You hit a certain wall when trying to treat somebody, you want to help them out. They're not sleeping. It's super important. So you start them on this thing, and then that's the thing that works, and then it keeps on going, But now as more time goes by, more research is done, and the underlying issue is hormonal dysregulation, then, and it's awesome to see studies like this, which is, this is more on the mental health side of things, but hopefully opens up the door to more funding and research on the hormonal side related to this that's going to improve outcomes overall.
Well, it's the cascade too that, you've got a lot working against you. There's stress, and that's a lifelong thing. Stressor is life, and how you're perceiving it and how you're dealing with it. So you have that anyway. Now you also have TBI, and all of your hormone levels are getting thrown off because of that. You got low testosterone, so you're not really dealing with things the way that you should be, which increases stress. That also affects your sleep, where you have insomnia, which increases your stress, and it decreases your reaction time and all the things. It increases your cortisol, which affects you hormonally. Again, it's just this snowball. I think that just, it begins and it just continues. And then we address like, I can't sleep. Okay, take an Ambien, or drink or smoke weed, or, you treat the symptom. And it's like, nobody is looking at the source of this, the beginning of the cascade, and being like, we need to address this and this and this and this with hormone therapy, with, a lot of the treatments that I've been lucky enough to go through some, different programs and different studies, that I think are part of, not the whole answer. And, what works for me doesn't necessarily work for everybody, but I think there's a lot out there that the guys are staying away from. And also another culprit is going to be, because some of these other treatment modalities like psychedelics, they immediately ixnay you from a security clearance. And there are guys out there that are still working and doing other things outside the military, where their security clearance is their livelihood. If they lose their security clearance, they lose their job, they lose their pay, they lose their purpose, they lose their house, their ability to take care of their family. Like, it's like, I have to suck it up. I can't get the treatment that I'll do that later. And then they hit that point where I was sustaining and I was surviving, not thriving, but surviving. And now I hit that wall. I can't anymore. And that's when they choose to, in a lot of cases, in more cases than I would like to ever accept, they choose to take their own life. It's great that they're doing this anyway. Sorry, I went a little bit of a tangent there.
That's good. So one of the things that I was taught by Dr. Mark Gordon was the pregnenolone steal syndrome. So the question that I had was, okay, so cortisol is elevated. What's that got to do with testosterone? And if you look at the cholesterol cascade from cholesterol down to testosterone, or cholesterol to cortisol, your stress hormone, your body will pretty much always create cortisol at the level it needs to survive, because that helps control a whole bunch of things in the body that you need for survival. Testosterone, it doesn't absolutely need it for right now survival. If you look at the cascade, it goes cholesterol, then it goes down to pregnenolone, progesterone 1, progesterone 2, DHEA, and testosterone. It'll convert over to estrogen, or it'll go down to DHT. Or it goes from cholesterol to pregnenolone down to cortisol. And I might have messed one or two of those up. There's a lot going on there. But the end state here is, if you're using all your pregnenolone to make more cortisol, which is required over time with mental and physical stress, that's your stress hormone, fight or flight. If we have high levels of cortisol over time, your body demands that you make more and more and more and more. It gets used to that. We can see that in people that go in for a surgery. If you're on chronic use of a steroid medication like prednisone, let's say, there's a number of different reasons to do that, but let's say you're on a higher dose of that and you've been taking it chronically for a long period of time. When you go into surgery, they have to increase your dose because the stress your body's undergoing during the surgery, and your body essentially has shut that down because you're taking it in exogenously. So now we have to increase your dose. Well, imagine the body's doing that on its own over the course of a decade, where it's increasing it slowly but surely, and it's using all the precursor pregnenolone to make more cortisol, as opposed to going down the cascade events to make testosterone. So then we end up at this low normal testosterone level, where you're not below the thresholds that Western, medicine has accepted as low testosterone and needing TRT. And so that's, a lot of guys, and even in here, I think at some point they talk about testosterone levels being normal, like low. Here, some data suggests operators have total testosterone below age-based normative reference ranges. So why is it that soft operators have low testosterone or low normal? It says below age-based normative reference ranges is exactly what they say here. So why? Well, what I just explained is an idea as to why. When somebody first gets in the service, the person that will become a software operator, are they less likely to have high testosterone or normal level testosterone, or does it happen somewhere along the way? And so to my understanding, there is work being done on that. But either way, all the guys I know that have gotten started on TRT, a lot of their other issues start improving. It's not the end all be all. And there's a lot that goes into it. It's not just looking at total testosterone and saying that's the answer. There's a lot of other things that go into it, even as simple as vitamin D. For whatever reason, vitamin D is very, very low in our population. And so then it's like, well, let's correct that before we start treating anything else like related to depression. If we correct the vitamin D, there's a chance. And that's a very simple, easy fix. Let's start there. And then we can continue to dive into these other things. And then they note here that this is his words, not mine, or the study's words. The only way to diagnose hormonal imbalances through diagnostic blood tests, I agree, which care providers often neglect to do. I wonder. I mean, when you talk to guys, I think it's becoming more normal to get these different labs, at least in the circles that I communicate with. So I don't know how much I agree with this statement. Providers often neglect to do. Maybe in this group of 50 that he spoke to, most of them didn't have blood panels done for hormonal dysregulation. I think it's not a thing that primary care or somebody wouldn't get labs on, at least to get a base value on. How they treat it's a different story. And, different insurance companies have different requirements. Different states have different requirements. The VA has their own requirements. The DOD has their own requirement. Everyone's got their own kind of status quo on stuff. I don't think anybody has a standard for what has been described as operator syndrome, though, because it's not even a diagnosis yet. So what do you do with it?
And I think there's a lot of guys in the community that got on. I mean, it just depends on why you're getting on TRT. Like, are you low and you're having issues and you need that for that reason, or do you just want to recover quicker and continue to operate and you're just an older guy? I think that and in that case, it's all it's the buddy system. It's like, this is what I got, this is the guy I use, I go to whatever, however you're getting it, and I think there was at least, kind of in my generation and the generation before me, that was a big, that was prevalent. It was around, there were guys doing it for that. So I think it just depends on who you're talking to. And me personally, I never did it before. I can tell from my physique, but I did it because it was low for me. And I went through the endocrinologist route and spent the money and have been on it ever since. They regularly do blood, every 6 months, I think every 5 months, I do blood testing and make sure that I'm on the right. Still, everything's still good. So, and I've made changes to my prescription over the last, 10 years. So,
yeah, there's people, if it's not managed well, it can be dangerous. And I think people discount it. So it needs to be a managed thing, and just to go off on your own and get it through a buddy from, some website somewhere or whatever you're doing. There's contamination. If you're not getting your blood labs done, you're not going to know if your hematocrit levels going out of control. You're not going to know what it's doing to your estrogen levels. If you're taking, anti-aromatase medications with it, If you're doing that and your estrogen level goes too low, it increases the risk of a whole bunch of other stuff. Thumbs up again. If you have a high conversion to DHT, it's an increase your risk of hair loss and different things. So that it needs to be managed well. So, and that's where if it's in the system and there's a standard that's created related to this for guys, then I think, because even diabetes, guys will be pre-diabetic, and there's a high correlation between diabetes and low testosterone, and you can increase your testosterone, and pre-diabetes corrects despite anything else.
Wow. Okay.
There's a lot that goes into it beyond just getting a total testosterone and then saying, yes, let's start you on TRT. You got to make sure it's done the right way. And there's other reasons besides just having a low total, like the ratio between free and total sex hormone binding globulin. How much how much of your total is tied up in your sex hormone binding globulin? Because once it's attached, it's not usable as free testosterone. So you got to look at your free testosterone levels. So there's a lot that goes into it, and there's a lot of training that goes into it too. And I don't know how many providers feel comfortable in that realm. If you just go to your general practitioner, if they haven't been trained on it, they don't experience in it, they're not going to be so quick to prescribe, even if they know it would do you benefit. But hopefully in that case, they get you over to somebody and refer you or consult with somebody that's more comfortable and trained and can do it safely and appropriately. So we talked about TBI, we talked about endocrine. Sleep disturbance is the next one on the list. I think in his book, he does a really good job on the sleep section. I really liked reading that. The presence of sleep disturbances is from the study here. The presence of sleep disturbance among operators is nearly universal. Whether it's sleep paralysis, inability to fall asleep, inability to stay asleep, or waking up early, or waking up feeling unrested, sleep disturbance it's just all over the place. They go further down. They go into research shows that sleep disturbance is common after a TBI, occurring in 30 to 70% of individuals with head injuries. And they have a couple studies cited here. And that can lead to, so a TBI can change the brain's ability to appropriately control breathing during sleep and affect circadian rhythms via hormonal, there we go again, channels, such as the internal clock, and the brain may become disoriented. Yeah. So sleep issues. If somebody's super stressed out, I know when I get stressed out, if something crazy is going on, I'll end up waking up super early. I'm like, damn it, it's 3:30 a.m. Why am I awake? There's nothing I can do right now. Like, I don't want to eat. I want to go to the bathroom, and then I'm going to lay here staring at the ceiling for the next hour and a half. Like, I'm just going to get up, I guess, and I don't know, go have a cup of coffee or tea or whatever, and just be stuck in that awake state.
Just go jump in the cold plunge. That'll fix it.
Yes. Well, that'll wake me right up, dude. On groggy days when I wake up, that's what I do. Because you can't. I've tried to stay tired in the cold plunge, dude. It doesn't work. No, it's impossible.
Nobody's sleeping in the cold plunge. No one has ever died from exposure. No, I mean, I should say that from the cold plunge, but not like the hot tub. Some people like pass out in the hot tub and they get cooked.
Right.
It's not going to happen in the cold tub.
No. So another thing interesting here. So chronic sleep deprivation contributes to the increased risk of impaired immune functioning, diabetes or type 2 diabetes, heart disease, obesity, and chronic pain. And I know chronic pain's one that a lot of guys suffer from within this world. I mean, just the nature, carrying rucksacks and jumping out of planes, and if you're a diver, and a lot of running and PT and different injuries, shoulder, all the hip injuries. If you're not sleeping, you're not repairing, hormonal dysregulation leading to worsening pain.
Yep.
We put a lot of people get put on psychiatric medications to control pain. So if you can control the depression, it'll actually help with controlling chronic pain issues, especially when it's like a polymyalgia kind of thing where it's multiple joints and like that. You got to make sure it's not RA, rheumatoid arthritis, and something like this. But in those chronic pain situations, if you can get appropriate mental health, oftentimes it improves that pain more than any other pain medication, to include opiates, which in those cases seem to make things worse over time. It might help a little bit at first, but it's a hole I hate to see anybody go down.
Yeah, it's hard to get out of too. I mean, I'm sure I haven't had personal issues that I don't like pain meds, and I'm actually allergic to opiates. morphine, any of it. Crazy. I just found out because I just had speaking of hip, of injuries and chronic pain, I just had my hips replaced. It was funny. They asked me, what'd you do to make them this bad? I'm like, I mean, I don't know. I think back to rucking, like
steel boots.
Yeah, my run in the Navy of steel boots. So that was what happened. It was the beginning. Definitely wasn't good for my hips. Rucking was probably the biggest, carrying a 100-pound ruck and trying to be sneaky, walk softly and fall or falling and getting crushed, your face getting pushed into the dirt and the ruck pushes up behind your head and pile drives you into the ground. I'm like, what? I mean, I don't even know where to start on like what I did to my hips. Like, was there one thing? No, there wasn't a car accident or a major event. Although most of these events would have been major for most people, I think. It was like, I remember this time I did a 100-pound ruck march for all night. And at the end of it, I felt like I popped my hip out of place or something like that would be the thing. But I'm like, it was kind of normal. So I don't know how many, all of it.
Sounds like mental weakness to me.
That's what it was. Yeah.
Yeah.
Bad genetics. Bad genetics. It's bad genetics. I didn't think I had bad genetics till now. Now I just think it's just getting old.
Yeah. Yeah.
Catches up. But they gave me, they knew I was like, cause when I was 12, I had surgery on my hand. They gave me morphine for the pre-op. And my priest from my church came in and to like give me a blessing before I go into surgery. I remember being so uncontrollably, I'm 12, right? You don't tell anybody to fuck off, but the priest walked in and I told him to get the fuck out of my room. I didn't want to talk to him.
Wow.
It was like I was possessed. So since then I've been like, it makes me angry and you guys probably don't want to be around me if I'm angry like that. So I prefer not to take it. So they gave me Versed, which was, this time around, I'd never been knocked down this hard with Versed, and I had retrograde amnesia. I'd never had it before with Versed. I don't know why, but I'm just more sensitive now after at that point. But he gave it to me, and they started wheeling me out. I remember turning the corner, and then nothing. I don't remember anything else. And that's awesome. I'm glad. But they gave me, what did they give me afterwards? One of the pain med they gave me was an opiate, a synthetic opiate with Tylenol mixture.
Yeah.
They started giving it to me in the hospital, and I started getting itchy back, and I was like, I'm just laying and sweating, so it must be that. And I went for like a week, and I actually longer. I went like 2 weeks, and I went to my follow-up at like 10 days, and I was like, I got this rash. Like, I don't know what's going on. She was like, it's probably the meds. I'm like, I don't even know why I didn't think about it. Probably because I was on meds, I'm on pain meds. So I'm like, I don't know why I'm just itching, showering, putting I'm like, it's just the meds.
Yeah.
I don't know why I didn't think about that being a thing, but I can't take opiates. So that's kind of good.
Yeah. Until you need them for a big ass surgery.
Big one. But Demerol, not Demerol. Is it Demerol? Dilaudid. They gave me Dilaudid as my post-op. And I was like, that's pretty good stuff.
Yeah. It's what everybody asked for in the ER.
Yeah. I told him, I was like, I don't want morphine or any of that shit. Like, please just give me Dilaudid. I respond well. It works.
Yeah.
Puts me in the spirit world. So I don't like pain meds, period. I just don't like them. But yeah, chronic pain it sucks. It's definitely part of the matrix. There.
Well, go back to it, the sleep aspect. If guys aren't sleeping, they're not recovering. And then the hormonal dysfunction or dysregulation and issues there, and all these other, type 2 diabetes, like I can't remember where I heard it, but the rate of diabetes among veterans is astronomical, even beyond the general population, at least in some age group. I wish I had that in front of me, but it makes sense to me, especially if there's more sleep problems within the veteran population. Is that what's causing this type 2 diabetes more so than if everything else being the same, food choices, activity, all of that, if it's the sleep that's causing the problems, that is another underlying issue that needs to get dealt with. To go back to it though, do you fix the endocrine stuff first, or you fix the sleep first, or do you do it all at the same time? And that's where these organizations that put all this stuff together seem to have, I would imagine, have better outcomes. I don't have the data in front of me, but
you got to start.
That's what happened with
everything.
me. As soon as I started, I couldn't do it anymore, man. So I just started doing all of it at the same time, just focus on all of it.
Yeah.
And really had to focus and turn everything else off in life. And just, I'd spent for so long, I was trying to deal with everybody else's issues and, to make sure I took care of everybody else, but forgot that, like, if I can't function, then I can't do that.
Well, I think there's a dual-edged sword there, because I think it's, people that gravitate towards that small team environment and going through what they have to go through to get into that.
Mm-hmm.
And then it's beat into our heads with pain and suffering that it's about the team, it's about the mission, it's not about you.
Yeah.
And I think that you just continue. It's like, put it away. It's not about me. You take care of them. Do everything for everybody. And eventually it's like your tank's empty, and you're like, I don't even know how to address myself or ask for help, or what even out there. How do I even start doing something that's going to be for me?
Well,
and then
what
I
do you
feel
do
like shit for doing it?
When you're on the team? Yeah. When you're on the team, when you take a time out, what does that actually look like?
Yeah. You're a shitbag.
Hey, team sergeant, I need like 4 weeks off to go deal with my shit. Right. And then all of a sudden, it's going to depend on the team sergeant, on the captain and all the things. But like, how long have you been there? Maybe you had a really bad time at the Q course. You've already been in, you were 82nd, squad leader or something. You got a couple combat pumps. You come back, you go to the Q course, 18 to 30 months there, sustain some more TBIs. Your body's wrecked. You show up to your team, and then, hey, you're there for a few months.
I need to take a knee,
happens. I need to take a knee. Yeah. They're like, you just fucking got here. What are you talking about?
Back when I was, I think it's becoming, we're getting smarter about it. I think, across the board, it's becoming, when somebody says, hey, and you look at all they've been through and you're like, okay, I need to take a knee, man. I don't know what's going on. Like, just, and look at their lives. Look at what's going on in their lives too. Are their lives falling apart? Are they drinking? Are they, how are their relationships? How is that, all that stuff going? Once again, step out of the way we've been like ingrained and taught and look at the big picture, and take that kind of like we talked about, many times about as being a medical provider. It's my specific, experience with the VA, is there aren't, not all of them, but there are some GPs out there that it's the flow chart to know, or the flow chart to fuck you. Like, we're gonna, okay, you got this symptom. Okay, let's see what this means, that if this, then that, instead of being like, you're looking at it like, okay, they have type 2 diabetes. They're pre-type 2 diabetes. I'm not going to start treating them with insulin or that. I'm going to look back and be like, okay, what's his sleep like? What is his vitamins like? What's going on with his testosterone and endocrine system? And that kind of stuff. How's his diet? What's this guy look like? Instead of just being like, not even looking at the patient, being like, looking at your labs and you're sitting behind him or her. Look at your labs. You're pre-diabetic. I'm going to go ahead and send you over for insulin. It's like, how about you look at me?
That's it. You know what, dude? That's a really good point. I wonder, how a room is set up matters.
Okay.
And I don't think I've ever been in a provider office where you go and you sit down. Like, if I'm the patient, I sit down and we sit down like across the table from each other and have a discussion. I'm trying to think. I mean, a lot of these offices now, they're being designed with the rooms kind of in a horseshoe around a center pit, call it, kind of like, and then there's a hub where all the providers come into, the RNs, the LPNs, everybody goes to the middle. That's where all the work's done on the computers and stuff. So I can look over and talk to another provider or the nurse to talk to them and get some more information, whatever. There's a lot of good information sharing as opposed to making it like very isolated little pods or an office that you sit in and you're just isolated from everybody. How the patient room is set up would completely change the whole experience if we were sitting having a discussion
across face to face,
or at least even like next side to side. If a computer was kind of over here and you're sitting on that side of the table, I'm sitting on this side, and we're looking together at things and creating a solution, shaga, right? Shoulder to shoulder. That's an interesting idea. I don't know. Maybe it's out there and it's been looked at, but again, then you're working in a small patient room and there's a exam table and it's this classic style of doing things. But I try when I'm sitting with people to have them scoot the chair over or sit more shoulder to shoulder, but just the way the rooms are set up, it's a challenge. It's a challenge.
And it's, you're limited also because I've got a 15-minute, maybe 30-minute appointment. Probably not. It's if I'm my annual appointment is 15 minutes. And we got to get through some stuff. And they're putting it in at the same time. Okay, put an order for this, I'm going to do this.
Yeah.
And they're not looking at you. We're not evaluating. We're not interacting. It's like, we're just getting you done. Let's get you done. Let's get you this referral. Or no, we're not going to do that because of this. And now you got to do this to rule out this, to whatever. And it's just like, okay, I'll see you next year. You know? So yeah, I mean, you know what? I'm grateful for the care that I do get out of the VA. Is there bad? Yeah. Is it frustrating? Yeah. Does it take time? Yes. Do I understand sometimes why people are like, F it, and whatever that means for them? It's like, I can't do this anymore. Like, I'm getting the runaround. I'm not getting the treatment I need. I'm getting just pills thrown at me. Like, you know, I got nowhere to go. The rating system is jacked, but I got rating, you know, and I got a lot of guys that do. So it's like, you know, you have to work the system. You have to figure out the system and work with the system, and then get what you can out of the system. And then the rest, you're going to have to figure out on your own, man, or use your network. And that's, you know, one of the points that I'd like to make at the end of this is that there is a network. There are nonprofits. There are places that you can go to get both with someone to talk to, get plugged into a community. And there are treatment modalities out there that are non-standard that can be funded. You know, you can find ways to get it done. And you can find that help that's a little bit different than what the traditional means are providing at the moment.
Yeah. So that covers some of the sleep. Next is obstructive sleep apnea. And this one, I have a CPAP. I don't know. Do you have a CPAP?
I don't. No, I don't. Yeah. I don't have traditional sleep apnea. I do have. Recently, I've been since I've had my hips done, I end up taking a nap at some point. Because I'm sitting down and I'm just ate or something, so I'll take a little nappy. I've been waking up like during the nap and gasping, like, and I'm laying almost kind of up. I sit in a chair, like that's kind of the most comfortable thing. I've got like a recliner chair.
Yeah.
I move around a lot to what's comfortable. But in the chair, I've been taking a nap, but I'll wake up and like I said, and gasp and feel hypoxic. But I don't snore per se. I'm sitting pretty upright at that point. I'm not laid straight, you know, all the way back. I don't really know. That's just been during this experience, and I'm not on any pain meds or anything.
There's also central sleep apnea, which is different than obstructive. But with how soon after you're talking about with recent procedures and stuff, I wouldn't think too much about it. But obstructive sleep apnea, essentially, there's a blockage of your airway, generally your tongue, that falls back. Some people get away from it by sleeping on their side. There's mandibular devices where you kind of open your jaw, like you're doing a jaw thrust maneuver, similar idea. Yeah, so there's a device you can wear versus using the CPAP. Depending on where you live, it's important to, once you get your CPAP, have them do if you're still not quite, if you feel like there's still some room for growth, to have them do another hypoxia study or oxygen study while you're sleeping. You don't have to wear all the shit on your face because you have the machine there that's working, but without oxygen. And then you just wear your SpO2 or your oximetry device, and then they'll see what it's called an nadir, which is, I don't know, nocturnal something, but essentially it tells you your average of your SpO2 through the night. Okay. And then they can look at that data and they can associate it to the CPAP machine data that, they can pull all the information from that to see if you had leaks, like what time you went to bed, how you were sleeping, the rates of how you're breathing essentially while you're sleeping. Compare that, overlay it with the oxygen or the oximetry over the night, and then they can determine if you need oxygen. And so sometimes the CPAP's it's not enough on its own and you need further studies. But unless you first off know that that's a thing, and then second, talk to your provider about getting the study done, you're not going to know. Right. Yeah. So it's important to kind of track that. What I'm working on is, how do I fix it? Again, we identified it. I'm doing CPAP, and dude, my life I don't wake up with headaches. My mood's a lot better. I mean, with everybody, I think we can all improve with just in life but how do I stop using this damn CPAP thing? Like, what is it that, because you add up optic nerve damage and you add up, other stuff. And then now the sleep apnea thing, which is it's all part of the same deal that we're reading about.
Yeah.
Okay. So then what, man? I just want to get back to good. Let's get back to where we were. Maybe it's too far gone. I hope not. I'm not done fighting to figure out how I can get back to not needing a CPAP and this other shit and get my vision back. And not that I've lost vision, but there's like, what happens if my vision does go because I didn't improve it? Or like you said, like,
intervene with some,
whatever that looks like. And I don't think there's an answer yet. I'm seeing specialists and I'm doing all the things, and I'm just hoping that there's a way forward. And my life's pretty good right now. This is not me complaining, but just like anybody, optimization. Like, let's just continue
always
to make this better.
Yeah.
That's what we're trying to do here. And this human experience is like, make it the best damn experience I can get out of this world, so I can be bigger, stronger, faster in a safe way to provide more to myself, my family, my community, this great country, and the world, right? Like, how do I do that in all the different realms of life? And I think that's in our conversations. That's why we started this whole thing, was to optimize in all those different realms, body, mind, spirit, right? And how do we get there? I've identified it. Luckily, I'm pretty knowledgeable in this stuff. I reached out. I wanted to talk to him about it. I did the extra studies and all the thing. And then it's like, okay, boom, I got this stuff. Now what? It's like the train track stopped. Well, let's build some rail, dude. Let's see where we can go with this thing, and so.
But I think not to jump in on you, but I think one of the challenges with operator syndrome is that there are so many different maladies included in operator syndrome. So it's like, you got the train tracks, but I got a branch and go to a bridge. I got to go around the mountain. There's a lot of ways I can go. So, and I think, one of the things that maybe we can dig into is like, what's being done, what studies are actually being done in different directions, and what's not being done, and maybe that's the answer to what tracks do I want to build? Do you want to build?
It's interesting you say. So for my doctorate, we write our program had us write a scoping review, and the scoping review it's not like a randomized controlled placebo-based study kind of stuff. So what a scoping review, and that looks at like, does nicotine improve mental health performance, right? Or name a drug or whatever. And they'll do that. Or like one of the reviews we did, one of the other podcasts we've done, those are all more along the lines of a study that looks at what's better, A or B, or nothing. A scoping review looks at the available research in regards to a thing.
Yeah.
And then it finds the gaps, it finds the most promising, and then that helps drive and direct, that's a really good analogy. Which train track set are we going to build? Because this is economics, it's black and white. There's only so much money. Like, where are we going to put our time and money? Because there's only so many,
a difference,
There's only so many researchers out there. There's only so many grants. And that's just what it is. And you just got to accept it. It's not endless. Which way should we go? So that's an interesting one. So maybe I'll grab a scope, or try to find a scoping review in this realm, or in these realms, as to
be cool to do a more of a zoom out than a particular study, like zoom out to what's being done overall, and then where the gaps are, Yeah.
Well, we can start with my paper, where I discuss psilocybin, the methods of administration, and psilocybin. And we're going a little off track here on this, but essentially the general outcome was, in the course of what we're discussing here, on what railroad tracks. There's been a lot of railroad tracks put towards what's the right dose of psilocybin in the treatment of depression? How often should you do it? Those kinds of things. What was lacking was the psychotherapy associated to, and it was kind of undermined. Like, it wasn't described what they were doing in psychotherapy. And if we decide to do this one, then we'll talk more about it. But psychotherapy is not really included. But if you look at the durability of effect, how long the effects of, how well it controls depressive symptoms over a year. The studies that described at least somewhat of what they did in psychotherapy, and the psychotherapy aspect, had great durable effects. They lasted a lot longer, not that they were doing surveillance on those people after in a lot of the other studies, but it showed that with psychotherapy, they had these included, the durability of effects were there. So the conclusion that I had come to was, we need more research which drives the point. Those scoping reviews might be something that we look at for zooming out in what direction things should go, or at least give us an idea as to what should be done. Yeah. So that was obstructive sleep apnea, chronic joint, back pain, orthopedic problems, headaches, especially after 10 years, dude, or 15 years. Our bodies ain't made for it, man. They ain't designed for this punishment, you know? I had my shoulder done. A lot of dudes at the unit. I think it has the shoulder stuff. I really think it's plate carriers and rucksacks and carrying a weapon and do ready up drills. This is just for everyone out there that's still doing this kind of stuff. If you're wearing a plate carrier all the time, because this was my mentality. I didn't just wear a plate carrier. I wore my medic bag, which was another 30, 40 pounds on top of whatever plate carrier and all the shit I had on with the radios and all the things, you know, all the little tools. When you suppress your body's ability for the shoulder to rotate appropriately, and actually your humerus, the humeral head, that's the top part of your arm, where the head is, it goes into the shoulder, it actually drops slightly. It gets pulled down to create clearance to elevate. Well, if you're wearing a heavy pack, pulls down, or like pulls out and compresses that shoulder capsule. So you're just grinding your shoulder in the shoulder capsule where it's supposed to have space. And so that whole idea of like, do hard shit and you'll be good at hard shit. Like if you do it easy, you're not going to be good when it's hard. When you get into repetitions, in my opinion, don't do it with a bunch of fucking weight on your shoulders, because you're going to grind your shoulders into oblivion. Now, does that mean never do it? I don't think so. Does that mean never run in steel boots? I don't think so. I think it means that when you're doing the majority, I'm just going to throw a number, 80% of the time, don't do it with weight on your shoulders.
Yeah.
And then confirm the skill with the equipment you're going to wear.
Yeah.
Right. For some amount of the time. Don't just do it all the time that way, because you end up just breaking yourself off, and then you end up, 6 months to a year of recovery because you wanted to train in this hard way. But I got to take another potty break. You good?
Okay. Yeah, I'm good.
All right.
And live.
All right. So, sorry, I've been trying to hydrate. It's supposed to be good for your back and for your brain. Yeah, exactly. Well, and I have to counter my diuretic coffee that keeps me going. All right. So we were talking about, what were we talking about? Oh, chronic pain issues. All those years of abuse on the body. And that, again, it goes back to like firefighters and police wearing those damn belts all the time. In and out of cars. They go from sitting in a car for 6 hours and they got to chase somebody down. Of course, you're going to, I don't know how you do it. You're going to pull, of course, you're going to pull your hamstring, trying to hop a fence, cold. You haven't done your warm ups and all the other shit, or you're riding it in the military, riding in a truck for however long, or getting on a helicopter and taking a 45-minute flight into a target. You got 100 pounds of shit on, and then you're right into it, hiking a mountain or whatever you're doing. It's not like you're out there doing fucking a warm up before you get after it. So, and that's
like we were talking about, like whatever you're doing to initiate too, like jumping out of a plane, you have a hard opening, then you got a shitty landing, and you got to collect yourself and then pick up all your stuff and then go, like, or you're breaching, you take you're too close to the blast. Now you got to enter anyway and do your job. Like, and then all of that stuff together, because it's all part of it, right? You insert, you get to the objective, you actions on objective, and then you extract all of that. You're doing that like 25 times during that thing. It's like you have cold times, hot times, exhausted times, dehydrated, unfed, low blood sugar, but going. There is no, all of that is like, when they ask, like, what was the incident? It's like, well, that whole thing was the incident, like a whole list of incidents. Let me see which incident caused what. I don't know. All of it.
Well, when you have inflammation for, let's say arthritis, when you have arthritis and you have inflammation into an area, you have cytokines and interleukins that are released. They don't stop at the body. They cross the blood-brain barrier, which then that inflammation signal kind of goes everywhere. And if you have a lot of it, it's going to have an effect on depressive symptoms and all the other things that we're describing, the hormonal dysregulation and like that. So there's a lot to be said about the musculoskeletal and how it plays into all the other things. And then not being able to do what you love to do, because your shoulder or your hips, like your knees, your feet, let's say you got a a calcaneal spur. I'm seeing a lot of these lately with guys is calcaneal spurs, and you go on one run and then your foot's inflamed and you're limping around for however long, because you're the inflammation in the tendon, because you have calcification in the tendon. I don't know anybody that like just goes in there and gets that spur out kind of thing, So it's one of those things you just got to keep living with until like at some point, I guess they might go. I don't know, but I've talked to a number of different orthopedists. They're like, well, you just got to kind of live with it. That's what it is. It's like, fuck, dude. Well, that's after 20, 25 years of, rucking and running and jumping and, doing all this stuff. You end up with a calcaneal spur, man. That's it. It's the Achilles tendon just doing its thing, taking you out, But the overall inflammatory process of the musculoskeletal system then wreaking havoc on other aspects of your overall health, like the hormonal stuff, the mental health stuff, all that, and then how it can mess with your daily life, whatever it is you do, whether you can do the job you used to do anymore,
I think that's one of the big hurdles is not looking back at that as the litmus for living, thriving. You got to reset. I mean, as you get older, you have to reset that and not look back, because it's going to be nothing but like frustration and anger and impatience and additional injury, because you're going to push too hard, and you're going to end up injuring yourself. I mean, like you're talking about, go on a run with the bone spur. It's like, go get the bone spur fixed, man, if you can, right? Like my hips, it wasn't even about being able to get back to even the shadow of what I was able to do before. It's like, I just want to throw the football with my kids. I want to run with them, and I want to play with them, and I can't. I go play hockey, and I'd be down hard for 3 days, like not able to sleep. Like my hips were aching and just killing me. Like there's no, I just stopped playing hockey, and that's what finally made me, go and do the hip surgery. Is like, and I walk in, they're like, yeah, you're in a lot of pain. I'm surprised you walked in here. I guess I'm just that stubborn and stupid, like, I don't know. I think it's a huge mental hurdle is to kind of accept slow degenerative mortality. And resetting that bar of like, what is actually thriving for me now? I don't want to be, eventually it's going to be like, get up, go to the bathroom by myself, like that's going to be a big hurdle, a big thing that I'm going to be stoked about. But right now it's like, I just want to play with my kids, and I want to be able to do some stuff. I want to have an outlet, to where I don't go crazy. Whatever that is, physical outlet, I got to figure that out, but it's a new normal now, and I think with the new hips, I should be able to get back to like, where I could be competitive for me, but not competitive the way I used to be. Like, when I was in my early days, you can't, looking back is the enemy on that, I think. And I've been struggling with that, because I just got off hip, so I'm almost 5 weeks out from hip surgery, double hip surgery. It's about the wins today right now, like the micro wins today. Like, hey, I can put my sock on now. That's cool. Hey, I feel like I can, like, I don't have to walk up to an opening and turn sideways and walk through. And like when I get in the shower, I can actually like step and pivot into the shower. That's new. Neat. It's those things that you got to kind of just be grateful. I mean, you hear that phrase, like, be grateful all the time, but it really is about like celebrating today, right now, this moment. Don't look back. Don't look forward. Don't look where you want to be. Look where you are, and be grateful that that we are able to do the things that you can. And tomorrow will be a little bit more, and the next day a little bit more. 6 months, I'll be somewhere way past where I am now, but still staying in that moment. I think
it almost sounds like a form of adjustment disorder, just a lot more drawn out.
Yeah.
Like guys will get tagged with the diagnosis of, I know I was adjustment disorder. I think I was adjustment disorder coming out of the military, getting used to civilian life, or, if you retire from the police force or firefighter or whatever it is, adjusting to this, like you said, new normal. Those that don't adjust well get this adjustment disorder tacked on. And then, it's, with the physical changes over time, that's almost inevitable. There's these unicorns that are like 60 years old, still out rucking. And, I had an instructor in SEER when I was in the Air Force. This dude must have been mid-60s, and he outpaced everybody, dude. Like it was so impressive to watch him walk up a mountain, just straight back, and just like his legs were just ridiculous. And you probably think he was like 6'4", just unbelievable, but that's the unicorn. And for him to keep doing that kind of thing. But yeah, it's an adjustment to this new status quo after years of abuse kind of thing. And that's an aspect of the musculoskeletal thing within this whole process, termed operator syndrome, is, I guess, accepting some of those physical changes that occur, whether it's your hips are destroyed, or your shoulders, or your neck, or your lower back, or you got the Achilles heel, or whatever it is. Yeah. I hadn't thought about it like that, but you make a good point.
Yeah, you have to find your way to continue to contribute. I think that's what we inherently want to do forever, is contribute. I want to be productive. I want to contribute. I want to help. I want to make things better. Leave the place better than I came into it. So,
right.
I think it's just, you got to figure out what that is now. What is it today?
Yeah.
And don't chase history or future.
Well, it leads us right into the next topic: substance abuse. So guys that aren't adjusting well start self-medicating, right? And their statement, not mine, substance abuse is in the soft community is common. So whether it's alcohol or whatever else, I think alcohol is probably the most, accepted,
available and accepted.
Yeah, accepted in the sense of legal. And what they say.
I think it's part of the culture too. I think
it's shifting away. That's my opinion. Is it's shifting away, but yeah, it's accepted in the culture. It definitely in the past has been a huge part of the culture, huge part. And they state here, in part, this reflects a way to cope with pain, depression, loss, and sleep impairment.
Uh-huh.
So it's self-medication essentially.
Yep.
And wrapped up into this whole operator syndrome, situation. I'd assume out of the 50 that they interviewed, most of them, to make the statement, most of them had stated that they used some type of substance to cope and to deal with all the things that they're dealing with. They do note here, for anybody listening, alcohol does. So when you consume alcohol and then you go to sleep, you don't hit delta wave sleep. This is to my knowledge, which then reduces the amount of growth hormone that's released, and then will reduce recovery from injuries, which then just perpetuates all the orthopedic stuff and everything else that we were talking about, mental resilience and everything else. So I don't think anybody's going to argue that alcohol use especially heavy alcohol use, is good for you, but it's just identified here as something that's predominant and common within the soft community. The next one, depression and suicide. Depression in the soft community is common. There's an increased risk of depression in veterans with PTSD and or TBI. We also know there's an increased risk of suicidal behaviors following TBI. So I didn't look at these particular studies, 29 and 34. If anybody wanted to actually read those, I'll read off what they are. 29. So this number 29, sleep quality and emotion regulation interact to predict anxiety in veterans with PTSD. And the other one was 34. That was the first study. Suicidal ideation following traumatic brain injury. So there's a couple studies that note that. I don't know how acutely after, if this is like we were talking about the microconcussive type issues versus like one big serious TBI. But, depression and suicidality or suicidal ideation following TBI is it's a known risk factor and something that sounds like be almost causative. And then it goes on, just like we said earlier. Everyone knows at least one person, or at least through one degree of separation, somebody's taken their life within the community, which is, I guess this whole thing is partially in an attempt to reduce that.
We got to call it. We got to figure out what to call it before, name it, right? Name it before we can start solving the problem. So I think that has been a big, why the big, huge push behind validation of operator syndrome. It's like, you got to name the demon before you can exercise it.
Yeah, no doubt. Next on the list here, post-traumatic stress disorder. While relationship between combat and PTSD is widely acknowledged, we found relatively little evidence of this disorder in its prototypic form, that is, without or with fear and avoidance as central symptoms. I think that's as the aggressors on the battlefield not just stuck on a base, let's say you get mortared. Well, you saddle up and you go get them kind of deal. Oftentimes that's the mentality. It's not something where you're just sitting there like, oh man, I can't do anything about this. It's as the aggressor, that idea of fear is less central in what is being diagnosed as PTSD in soft veterans. And then stated here, virtually none of the operators reported fear or avoidance reactions related to thoughts or cues associated with their combat experiences. Moreover, a body of research suggests a strong link between TBI and PTSD, including biological explanations of how TBI weakens working memory, increased vulnerability to developing PTSD. So that's interesting that it's not the prototypic PTSD, maybe a subset, and maybe this whole thing is a subset of PTSD with TBI interrelated somehow.
Yeah, but I think it's also looking at this from the perspective of like the high mileage guys, whether it's high mileage time spent in or it's time spent in and then their life has gone by and they're high mileage in that respect. You choose your fear. There's no fear of being the guy, of getting to take action and do, but there is a significant fear in losing that ability over time. You can't be the guy anymore. You're not the guy anymore.
Right.
You lost your team. You lost your purpose. You lost your mission. Who the fuck are you now?
Yeah, well, that's that adjustment disorder piece that I was kind of alluding to, that it's seemingly almost a form of that aspect that you just described as like a form of that adjustment to relearning what all of that is.
Yeah.
Because you took off that armor that was you as a SF guy or a Ranger or PJ, CCT, name it, SEAL, whatever. And then now you're in civilian land and you're working in corporate America. And so I have seen where guys just kind of hold on to that and it's like you're going to kill them if you take that away from them, and that's the first thing.
Actually,
yeah.
It's like choose your fear, right? Like, I think it's still fear-based, but they're not afraid of it's not because they can take action. They've been trained to take action. That's honestly, probably what makes you feel alive, like a large part. And the fear of losing that, I think it's still fear-based. It's just choose your fear.
Yeah. It's just different, huh? Interesting. Yeah. Well, I thought it was interesting though that they noted here that it's not a typical PTSD pattern.
Right. Yeah, I would agree with that 100%. We've all seen some really, I'd say we've all seen some really fucked up shit that would traumatize, somebody who wasn't prepared for that. And I'll use a close friend of mine that was a dust-off pilot. And he has a huge issue. Like, his demons are the fact that he was flying, blowing up people in the back of his aircraft. So he had to see all of that. And pilots aren't really trained to deal with that. But these medevac pilots, dust-off guys, they have to look at that stuff. And they have to fly as fast as they can, as safe as they can, and make sure that that patient gets to the next level of care. Yeah. And they lose some, whatever. But like, that was probably much more traumatic for the pilot than it was for the medic, because the medic's been trained and is taking action. Even if they seek direct contact with these wounds, combat wounds and stuff, we've been trained, as medics, being a Delta, myself being a PJ and a prior corpsman, like you get trained to deal with the medicine. You go into your protocol. Like, I got to amputate it, whatever. I got to put a tourniquet on. I got to, start an IV, do the interosseous. We're going to do TSA. We're going to do all the things. You're running a flow chart in your mind of how you're treating this person. Pilot's just flying, hearing the screams and, completely out of control as far as what's the outcome of that patient. So I think and they haven't gotten the stress inoculation of medical treatment. Like, we went through extensive schooling to prepare us to be able to act in those environments, on the battlefield, when to act and when not to act, self-aid, buddy aid, medic aid, kind of thing. That takes how long did it take you to go through 18 Delta?
30 months.
Yeah. 30 months of training, of medical training. It's like, that's a lot of fucking time, to be stress inoculated for sitting there with a patient and dealing with whatever you're dealing with, Yeah. So I think, anyway, that popped in my head about, it's not always it's not always what people think should be a traumatic event that is the traumatic event, depending on how you've been prepared for that traumatic event, you know?
Yeah, it's interesting. And even I'm trying to put myself in the position, like the thought process, and I'm already thinking of questions that a pilot could ask themselves. Did I fly fast enough? Could I have gone faster? Could I have landed better? Could I have landed closer to the X?
Right.
If I had taken more risk, would that 30 seconds have changed the outcome? So all this shit running through your brain as a pilot, you know, me as a medic in the back or on the ground, I might know that wouldn't have changed the outcome, but the pilot will have that question for the rest of their lives. Yeah. And they won't necessarily know unless they work it out and go to a group with a bunch of medics and talk through the process, what actually happened, and then, you know, there's some different psychotherapy processes, and it's actually kind of what it goes into too. Those classic, I think I mentioned it earlier on, those classic forms of therapy tend to work well in those populations that are not the soft population. So I wonder, that's an interesting point. I hadn't thought about that. So yeah, maybe that does have a lot more to do with it than I give it recognition for. Who hasn't had the angry team sergeant?
Who hasn't been the angry team sergeant?
So anger, some operators report problems with anger management and expression. I mean, it's honed into you. Like you almost got like it was like you got extra points if you were angry. Yeah. You had to turn you had to turn it on. The angrier you were, as long as it was a controlled anger and going in the right direction, not inward facing towards your team, but outward. You know, speed and violence of action. I don't know how to do that. I'd say most people do it with anger. Yeah. You know, and I think I would assume, and what I've seen, the more professional somebody is, the less angry they need to be to produce that speed and violence of action. And that's where you move more into the professional ranks of this industry or this. Yeah. Where you're talking about,
they run it at nauseum to where that action is just, it's part of the process. It's not even something that they're on autopilot, but it's autopilot is to take, there's no thought. I think, you know, when you become you look at a professional doing anything, like a true professional, where they've done hundreds of thousands of repetitions, you know, and it just is, you know, just flow or whatever it is, you know, tennis racket or hockey stick or, you know, baseball, they have, or golf club, they have so much focused agility and ability within that spectrum in their wheelhouse. You know, it's almost beyond comprehension for a generalist, which I think, you know, I'm a generalist in most things. I'm better at some things, but I wouldn't say I'm a professional in maybe medicine. I was, you know, that was what I focused the most on. I loved it. So, but everything else, you got to be a generalist, jack of all trades, master of none, you know. But if you get to the level where you can focus and that is your thing, then those guys, like, to watch them go through is poetry. It's a symphony. Yeah. And I think that it'd be really interesting, because I do know, I mean, I think we all know, you know, some people from that realm of in different areas, and they're not immune. I think it comes back, you know, and I think they've got their own demons, their own types of demons that they've got to deal with later on. It'd be interesting to see what, if any, are the differences between, you know, the generalist type from the career, from the community, and the, you know, the guys that got to that level and were there for long enough to see what, you know, kind of where they're at. And then you see some guys in social media and stuff. There are some guys floating around that you know, put themselves out there, how they're living. But it'd be interesting to see behind the curtain and really get the truth, you know. And I think, you know, I talked about the treatment modalities that I've been exposed to recently, and there's a community involved with that of guys and females and girls that have gone through the process. And on the other end, there's a lot of workshops. There's a lot of availability of community connection and talk via Zoom and events and stuff like that, and training, really, to integrate what the treatment modalities, kind of what you talked about with psychotherapy after psilocybin, is like it's more durable and it's more sustainable if you integrate. And there's lots of different ways to integrate. And in this community, there are a bunch of people that come from, a lot of those places that we're talking about where they're at that professional level. And I mean, we're all professionals, right? At the level that we are, but there's some that are so specific. We're talking about direct action. We're talking about, whatever the specific mission set is, they practice that and they're so efficient and they're so good at it that it's beyond, and there's money and support behind it and all that stuff, not to take away from the professionality of conventional forces or conventional SOF or anywhere in the hierarchy. I'm not taking away from anybody's thing, right? Anyway, there are guys that are in that community that I have access to now that have interesting takes on stuff, and they've come out of this particular treatment modality or series of treatment modalities and had a lot of relief and a lot of peace because of it.
Yeah, well, to go back to anger, I guess I initiated this with, I don't see anger driving them or turning up the volume in terms of their awareness of a situation or ability to act with violence, speed, action to do that. It's just inherent. And where I'm saying early on in like the Q course, I would turn the volume up on anger in terms of an emotion to drive me to do whatever it is I needed to do, whether we were training an ambush or whatever we're doing, as opposed to you watch somebody or are trained by somebody that has done this that many. They don't need that to turn up all their senses and everything else related to that, stress performance curve.
We're talking about like a flow state, to use the current term.
Okay, so that's the in vogue one. So it's just they're already there, as opposed to using anger as a way to do it, which is continuously reinforced and it works. And so you find something that works, that gets the job done and gets you the pass, and then continue. He keeps thinking I'm doing a thumbs up, and then for anybody that's not watching, every time my hand goes into a semi thumbs up position, it does a thumbs up on the screen. So it made me lose my train of thought. But anyhow, we're reinforced with anger. And so I wonder how much of that we bring home with us, as opposed to if it's trained into you and reinforced, then you have a hammer that works out here in this world. You're going to bring it home and and turn the anger on back home, which does not work for your family and your 4-year-old and all this other stuff.
I'll say even for those people that get to that level of focus and that level of repetition and that level of professionality, I'm sure a flow state is a flow state until it's not. Like eventually, if they're professional against professional, they meet resistance, they're still going to turn that anger up in that setting.
Right.
You know what I mean? Like if they get pinned down or they get, not everything's perfect, right? Everybody's got a plan till they hit in the face. And I'm sure it's got to be the same across the board, even for, the most elite planners of the planners, and the mission's been planned and practiced, and then they get there and it's different. And they have to flex, they meet resistance, they lose some guys, they got to push through. I think anger is always the default. It's been taught that when you meet that resistance, anger is the default. You drive through, and it's controlled and focused anger. Like it's not crazy anger. You're not just running with machine guns out into the belt. Maybe that happens, but I think we've been trained and taught that focused anger, focused beam anger is effective in those situations where you need to put through. Like you said, Q course, some moments in there, my training too. You're tired, you're beat down. It's been, whatever. Anger is the only thing that gets me up and going again, back in the fight. It's like, and I think that learning that same thing with stress or pain is like, I go into my pain. I used to call it the pain cave, right? Your happy place. Yeah. You go there, and I still use that place to this day. So, I mean, I think anger is definitely a default switch, and that I think that when that gets clicked, just becomes different depending on the situation.
Yeah. Well, and what they bring up here, some operators report problems with anger management and expression. So it's the placement and timing of that anger that's, it's when you default back to it because you meet resistance in your life because your whole fucking existence is falling apart. You intimacy problems because you can't get an erection, your body doesn't work, so you can't hit the gym like you used to. You're having trouble focusing. You're not remembering things like you used to. You forgot to pick the kids up today. You're readjusting to a new lifestyle. And it's a totally different set of responsibilities and the chaos of a family and being part of that team at home and all that shit put together. And then, like you said, you hit resistance, which is life, especially once you adjust to outside or if you're home for too long, and then wham, default to anger. And so I think that's what they're getting at here. And they state here, which is this problems with anger management expression, which is not surprising given the high rates of TBI, pain, sleep disturbance, and depression. And they say targeted psychotherapy psychotherapy component for anger management has been shown to be effective for combat veterans. So first identifying if you're having anger issues, and then bringing that up to whoever you talk to in behavioral and mental health. What they're saying is can be a benefit. How that's different for a soft veteran, or if it is different, that psychotherapy and management of anger and whatnot. And again, this goes back to doing all the things at once to hit the threshold of that enzyme to then start moving the chemical reaction in the right direction. Because if you tried to just do, I'd imagine with a lot of my buddies and myself included, if I tried to do just psychotherapy, which I did at one point, there's no movement, man. Nothing happens. No. But then you add the physical therapy, add the hormone replacement therapy, which didn't even include testosterone for me initially. That was the catalyst. All I needed was...
the jump to intimacy has got to be the biggest jump, That is like counter vulnerability and intimacy. Like to do that first, I'm kind of like, fuck you. That's not going to work. I don't want to do that. I don't even know how at that point, I think there are so many things that you have to deconstruct individually. Everybody's different, right?
Yeah.
I'm not saying it won't work for somebody.
That's
generally speaking. So generally speaking, I think that's a difficult jump is to go from anger straight to intimacy and vulnerability. No worries.
Yeah, huge jump. And as the first approach, but if in the approach, and it goes in here later, there's, what was it? The Center for the Intrepid. They mention it here somewhere. We'll get to it. But I had a buddy who basically was shot off of a roof, fell 2 stories, and his ankle came out of his foot, like his tib fib, like busted out, and his foot was no longer really attached to him other than by skin and some muscle and soft tissue stuff. He went down there to Texas to the, I believe it's called the Center for the Intrepid, and their total approach to everything was just freaking outstanding for him. He came back just glowing in terms of how much support he received from not just him, his wife, and then his docs would get together, would literally physically come together and discuss cases. And you'd have the mental health person and the orthopedist and the physical therapist and his nursing team, and all the people come together and discussed his case. So they all had a similar azimuth on where they were going with his care, which resulted in him returning to the force despite, all the catastrophic injuries he had and issues he was having. And then also made sure he got placement back in the military, back in the service, that was basically, he was able to operate at the highest level he could based on his physical issues and everything else, which all of that coming together for him has led to, he's in a good place. Yeah. But it took that team coming together to get him to a place, as opposed to kind of piecemealing it out where every specialty is in isolation. And I think the more we see of that approach, that where the medical community is able to come together, which is to try and coordinate that on the civilian side, is next to impossible. To get a surgeon and a mental
everybody
health
talking, at
the same time, just getting them on one Zoom call even would be very, very difficult.
Get them all to read the same chart, about an overall chart about a patient. Like, don't even include meetings or collaboration or anything. Like, that's not going to happen. I mean, they're just, because of the way the medical system is kind of set up currently, it's about volume. They've got to get people in and out. Surgeons have to do surgery. GPs have to do visits. They have to, everybody's got to treat people it's about numbers. Got to get numbers in, and I think I thought, I wanted to mention Exos, and Shields and Stripes. Shields and Stripes is a organization run by a PGA buddy of mine that they do a lot of stuff for veteran support. But one of the programs that they have that I am in the process of trying to get into is they'll send you to Exos. And Exos, for those of, I think most people know about Exos, but it's a place where they're doing just what you're talking about. And they do it for professional athletes. They do it for soft operators that are in, and then they do take in through some of these programs. There's a bunch of different nonprofits that do programs to Exos or similar facilities, but they have your whole treatment team there for 3 weeks. Your nutritionist, your dietitian, your chiropractor, your soft tissue person, your
strength and conditioning
person,
yep,
a occupational therapist, all the different PT, physical therapist, and like they look at you as the holistic care unit, and then they look at all your isms and they communicate and they develop a treatment plan for that 3 weeks, and you run through, and they watch you, and you have meetings every day with all of them, and you get fed all the good stuff. Like, it's just a way to physically get a reset. And then Shields and Stripes also has their total program is 3 months. So they provide counseling and coaching and all of that throughout the whole experience. And you have a cohort of 7 people. It's an 8-person thing, so 7 other people that I would potentially get to go through if I get accepted. Where you're with a group setting, you're on group calls, you're on individual calls. They've got this whole system built out. So great program for that kind of reset.
Yeah, I got to go to Exos some years ago. I went to the one in Florida.
That's right.
Dude, that place, unfreaking believable. They got all the cool little bells and whistles and stuff, and they got all the cool, like, the underwater treadmill and the pneumatic, like, basically they can control the amount of weight on the treadmill so they can reduce your overall weight that you're running on.
Yeah.
All that kind of stuff. It was an unbelievable experience, and it was a true, like, physical reset, like you're saying.
Yeah.
A lot of my back pain went away, and that was I ended up going through the SOCOM Care Coalition, which if you're still if you're in the National Guard or you're active duty, I don't think they do veterans. That's another, instead of having to go through the Shields and Stripes, if you're still in, you can, if you have a significant injury, or even just an injury, you can always reach out to them. And that's another great program that can facilitate. They can't pay for all the things associated, but then they get you connected with the nonprofits and stuff that'll help cover some of the other costs, whether it's the flights or the meal programming or those kinds of things. So yes, yeah, I absolutely love my time at Exos. They have one also in Phoenix, and they have one on the West Coast, like Southern California. I think they're based out of Phoenix. All right. So this one blew me away, man, reading this. So marital, family, and community dysfunction. So the divorce rate amongst operators is high, with some reporting the rate for their unit to be over 90%. So all this stuff we're talking about so far coming to a head and absolutely destroying the family unit and leading to divorce and all the issues. And, so many of our guys are divorced, and then after a few years, maybe they've worked on themselves and like this kind of changed their lifestyles and or what they're doing to cope with the different things, and then they end up in a good relationship eventually. So all hope is not lost, but if we can reduce that number significantly, it's just going to be beneficial. They got married in the first place for some reason. They were in love, and things fell apart as the disease process continued. I don't know any other reason the divorce rate would be over 90%.
Yeah, that's pretty high.
That's crazy.
Deployments don't help, and being away and that kind of stuff. But that would still, even if it was just that, it would still be I feel like a more normal number. If you could compare it to like any profession where people are taken away, on a regular for more time than they're home. There's got to be more to it for a 90%. That's high, really high. And if I think about it, most of the guys that I know are at least divorced at least once, if not 2-3 times.
Yeah, I got real lucky with
4.
I got real lucky with my choice for life partner. We've been together for 17 years, but that doesn't mean there hasn't been times of, fucking close to that nuclear bomb going off and just
life happens, man. It's hard.
Yeah. And then problems with sexual health and intimacy. We kind of touched on this earlier, but we know that this is their words. We know that TBI can affect endocrine levels, specifically testosterone, which has obvious consequences for sexual functioning. So with that low normal that doesn't necessarily meet most insurance, state, federal levels for getting testosterone replacement, we're still seeing, sexual dysfunction and intimacy problems related, that can be devastating to a relationship and to just one's value of self, when you can't engage in that aspect of life.
Well, that goes back to that fear base, not being able to perform as a man should, as however this manifests, whether it's physical or whether it's sexual or all of it, relationship, however it's going to manifest, it all is a hit to that, and I think that kind of not going to say it's one of the main factors, but I think it does contribute quite a bit to the snowball of, once you start going down the road of losing your potency and however it's manifesting, like I said, that's going to compound. It's going to get worse. Like if you have a problem with intimacy, it's not going to get better as you move through this with all of the things that are going on. If you have problems with erections or getting it up, like that's not going to get better with, trying to make it better. Like that's the opposite of what needs to happen. So it's, thinking about it's the worst thing you can do, or worrying about it. Like, am I going to be able to get it up? Well, absolutely not. Now we're not, anyway, we'll stay away from the verbiage around that. But, it's, I think it's going to manifest. It's going to come up. It's going to happen. And that's to me, it starts striking at the fears that we all have of not being able to be who we think we're supposed to be.
Yeah. A person's identity. Next is being on guard or hypervigilant. I mean, there's not much else to say about that. I think it's like a conditioned state.
Yep.
I don't know what else to say. If you're driving roads for 6 months, a year, 18 months in some guys' cases, and then going back and doing it again over and over and over. If you're not hypervigilant, well, you're going to get blown up.
Yeah.
Or you're going to get shot.
Somebody else is going to get blown up and it's going to be your fault.
Yeah.
Or you're going to,
yeah,
that's inevitably, a bad outcome comes from not being hypervigilant.
Switched on. Yeah, exactly. Yeah. Memory, concentration, and cognitive impairments. Most operators report impairments in memory, concentration, and cognitive functioning, which are common in veterans with blast wave exposure. The one thing they didn't mention here, which I thought should have been, but it's also intertwined in all this, is depression. Memory goes way down when someone's depressed. Recollection of events, or just small little things, it goes way down with depression. But that is probably the first thing guys will come talk to me about is memory issues. And I think it's not a hit to their ego. Nobody wants to come to me and talk about their dick not working or them yelling at their kids because, I don't know, they're playing soccer in the living room or they knocked a glass over of milk or something on the dinner table and they lost their mind. They don't want to talk about that stuff because it's a hit to their ego. But the cognitive impairments seem to be the first thing that they want to talk about. Then I start digging in a little bit and asking about these other things and just expressing like, look, these are things. I usually start the conversation, that next phase of the conversation with, well, if that's happening, are any of these other things happening? Because this is a common thread amongst those that start having these cognitive issues, and not being dismissive of it. Like, well, everyone forgets where they park their car, or oftentimes, even before you join the military, how many times you lose your keys, or did you not remember your PIN number on your debit card or something? But these other things in conjunction with, that's where it's like, okay, we got something to talk about here and to work through, is what I've found. Vestibular and vision impairments, these are their words here, although poorly understood, many operators report impairments in vestibular and vision functioning, probably in part because of the shearing effects of blast wave exposure. So vestibular has to do with the inner ear. It has to do with your balance. So that could be walking into door frames and just being off balance. Vertigo, vestibular vertigo is essentially where you don't know where your head's at in space, or your body positioning in space compared to your eyes, and it leads to, nausea, vomiting. Think about like if you're on a boat and the boat's doing its thing, but then your vision, the room's still flat relative to, and you get sick kind of thing. And they say, go look at the horizon. So then it puts everything into perspective for the brain. So that's a vestibular impairment, would be, but you're not on a boat, you're just on dry land and you're off balance and these kinds of things. There's another noted disturbance that they found that was common amongst the SOF operators. And then the adjustment, so challenges of transitioning from military to civilian life. And that's that, like we were talking about, the adjustment disorder stuff that you cued in on. Yeah, they mentioned that life outside the military is typically more mundane. Like you're not going into life or death. You know what I have found though, a lot of dudes from the SOF community, we find ourselves getting into career paths that are a little more dangerous. A lot of guys they want to be sheriffs or deputies, police. They typically want to get onto the SWAT team and do raids and do warrants and stuff like that, or they take contracts overseas to continue doing what they were doing in that similar realm, to essentially to not adjust, to stay in the fight or to find a new fight kind of thing.
Direct application of their skills too. More of a direct application than a lot of other stuff.
Yeah, there's so many programs for transition out there, but if it's not going to lead to getting that adrenaline dump, I don't think guys are super interested in it. I don't know. What do you think?
Yeah, I would agree. I was thinking entrepreneurial too. There's a lot of, it's a different kind of stress, and it's a different kind of live or not live when you're talking about building companies and building stuff like that. But I think there are a lot of guys now that are getting into like small business and that kind of stuff for financial reasons, and a lot of them are thriving. I think it's a move away, because I think the old way was a lot of guys would go, they retire, they'd get out, they'd go where they either go contract for a while, they'd drift into a job that was a sales kind of position or training or something that still was a direct application of their skills. But I'm seeing a lot of the younger guys now, whether they're in or out, and they're jumping across and very early starting a business to exit with. Like they're looking at the exit out of the military and having something built and having an alternate means of making money, passive income type thing. And I think that's the entrepreneurial path is risky. There's huge wins and there's huge lows, through that. So I think those wins, it's an adrenaline dump, for the, when you can actually do you can defy what most people think you'd be able to do, to build something and be successful. So by current standards,
So maybe that should be part of the discussion when choosing a career path, when getting out, then, is understanding that life is probably going to be mundane, and choosing something that's going to fill that part of the cup somebody in this world would need, when making that choice on their transition. That, hey, we gotta do something that's going to get you an adrenaline dump at some point, in some form or fashion that you can be proud of, and that fulfills you in that way. And it's probably not going to be, hopefully it's something safer than getting shot at or getting blown up. You know? What else here? So existential issues common to operators. So these are things so I'll just read it straight because he says it so eloquently. A number of common existential challenges are faced by members of the SOF community that requires nuanced and contextual awareness by clinicians. So this is more, if you're a clinician out there listening or watching, these are things that are common to SOF operators, and it's a mindset that discounts the future. This means they often have trouble implementing a daily lifestyle that will maximize health and quality of life in later years. So it's like, oh, fuck it, it's never going to get better, so why do I care? So working on that purpose, working on that future, giving them something to live for, and not that somebody could give something for somebody to live for, but to at least have the conversation to identify that, and then working through, it could be vocational rehabilitation, which the VA does an amazing job with, I think. They helped me get back on my feet and go to PA school. I know that they can do stuff with opening businesses or starting businesses, getting training. to whatever profession makes sense for whatever somebody's disability is hindering them from doing whatever they would have done when they got out. If there's something in the way, they help break down those barriers. The next was loss and grief, survivor's guilt, and the meaning of killing. So just understanding that anybody in this world has had a significant loss. Everybody has had a significant loss. I don't know too many guys that haven't had some kind of loss, whether it was somebody taking their own life or in a combat situation or in a training situation, something like that. Fear of developing invisible wounds. The fear that of all this shit happening that we've talked about so far, seeing your buddies and people in your community that have gone down this road and having some fear that those kinds of things are gonna happen to you next, is something that needs, operators, soft guys are dealing with mentally. It's just an added stress, which might lead back into the mindset of discounting the future. And what else? So there's a pervasive awareness in the soft community, the invisible wounds of war, including CTE or interface astroglial scarring, may claim them too. So the thought that you're going to be all jacked up, not too distant future, is going to lead to, in my opinion, probably lead to more of discounting of the future. And the confluence of overlapping and interrelated factors create a vicious cycle, resulting in a soft operator with compromised functioning and impaired ability to transition to civilian life. So these things are running through guys' heads. And then, hopefully people listening or watching have access to the study. They have a pretty good graphic on here that lays out the interrelated nature of losses, injury, psychological factors, and biological dysfunction are all things that we've talked about so far. And they laid it out in a nice graphic. So if seeing it is better than hearing it, definitely worth looking into this and reading the study yourself. And then in the discussion here, this is their words: because of the common patterns of interrelated medical, psychological, and quality of life impairments in this unique group, including TBI, endocrine dysfunction, sleep disturbance, obstructive sleep apnea, chronic joint back pain, orthopedic problems and headaches, substance abuse, depression and suicide, PTSD, anger, worry, rumination, and stress reactivity, marital, family, and community dysfunction, problems with sexual health and intimacy, being on guard or hypervigilant, memory, concentration, and cognitive impairments, vestibular and vision impairments, challenges of the transition from military to civilian life, and common existential issues. Together, these difficulties may be understood in part as the natural consequence of an extraordinarily high allostatic load. So allostasis is the regulation of hemostasis, and allostatic, this is from a 1993 study by McEvan and Steller that described this in 1993 as the study was stress and the individual mechanism leading to disease. Allostatic is the wear and tear on the body. So what he's saying is all those things I listed and that we've talked about so far are potentially the result of this extraordinarily high allostatic load. So the wear and tear, that's both mental and physical. And as the allostatic load builds and both body and mind begin to wear down and manifest notably in a wide range of impairments during the later stages of a career and early phases of transition to civilian life. So it boils all that stuff down to this idea that this extraordinarily high allostatic load leads to these things later in the career. In my experience and talking to guys, it starts generally at about year 10. It's about a decade. So at year 10 of doing this, then that's when things start and they just progress on and get worse and worse and worse and worse until there's intervention. And like you said, I'd be curious to pick your brain a little bit about some of the stuff that you've seen work really well, whether it's nonprofits. You mentioned Shields and Stripes. Shields and Stripes?
Yeah, Shields and Stripes, yeah.
So as one example of a nonprofit that's doing work in this realm, at least for the body aspect, what's the one that does the hormonal replacement and
Warrior Health?
Warrior Health can help guys with in the endocrine realm. So there's nonprofits essentially that are working in these different realms. I don't know of any that are doing all of it all together.
That'd be too expensive.
You got to, well, right. And so you got to piecemeal it together and knowing these different ones. Can you think of any others that are doing work in this?
Yeah, I mean, SOCAF, they're doing some good stuff. They have huge waiting lists for most of their stuff, but it's great programs. That's SOCAF, SOCAF.
I think it's just F.
Is it
Special
SOC
Operation
F?
Care Fund. Yeah.
That's what yeah, sorry. Yeah, SOC F. And then there's Vet Solutions.
Yep.
That's run by some SEALs and SEAL and his wife, and they've got a wonderful program building out, kind of wrapped around informally a week of psychedelics down in Mexico. They have different sites. They've got some different places and stuff they've got access to that they can get guys and girls, women down to. And they do the program for operators and their wives as well. So that's a great, kind of addressing the whole home unit, because if operators, guys that have been doing the job and they've been working a certain way and they have a certain rhythm with their families, and specifically their wives, or other way around, wives with their husbands, then it's gonna, one person gets fit, gets well, sees the light, starts feeling good, starts spending time with themselves, inevitably there's going to be a little bit of potential resentment and like, well, I want to get fixed too, and I had to deal with this all this time, and now you're good, and we just want to move forward, and whatever the case may be. But I think it causes some friction there in a lot of cases. So this particular program, they offer the wives or the spouses, I should say, to be able to go through the program as well. So with support. Now there's different funding levels. There's some grants. There's different ways to do it, but they're doing some great stuff. They have great programs before the psychedelic retreat, or the medicine retreat, I should say, and then post medicine. And these are medicines, in my opinion, after going through it. I think psychedelics lends itself to being whatever experience you've had or you've heard of, with just taking some mushrooms and doing whatever. Like, this is very focused. It's very trained, with intention, with counseling, with coaching going in, and then great support, amazing support while you're going through the week-long process, and then 2.5 months and then beyond, with meditation training and different clinics and coaching and just support. And it's all free. Of course, myself, after going through the program, I really want to give back and help, become a peer ambassador, go through the training, and want to go help with during the weeks down there in Mexico with other people going through. So that's a big part of their specific program, is people want to recycle in and give back and learn to meditate, become instructors, start helping people. And that's how we kind of, if you want to fix your life, if you want to change your life, change your circle. And if you can't change the actual people in your circle with your family and stuff, then bring them into the program. I think is kind of the thought process here. And then it expands out from there. And it really, I mean, in my experience, it really works. Great stuff. The specific psychedelics that I got to do, it was blessed enough to be able to partake in those ceremonies was ibogaine from the iboga plant from Africa. Mm-hmm. It's a pattern interrupter. It's been used quite a bit to counter addiction, heavy addiction, all of them. And I think the statistics coming out of the places that are actually doing ibogaine intervention with regards to addiction is there's a 50 to 60% non-relapse rate, which that is a ×5 of any program AA, any outpatient or inpatient program that's out there. They're getting like between 8 and 15% non-relapse. So that's significant. The ibogaine is a powerful pattern interrupter, and a lot more, but we only have so much time here, and I don't want to go too far into it. Maybe I'll do another talk specifically on that. Maybe bring somebody on that's gone through it as well.
Yeah.
And then 5-MeO DMT was the second one. It's also called the God particle. It's from the Sonoran desert frog poison is where they get the substance. And there's a process it goes through to where you smoke it, and there's a very powerful spiritual experience that comes out of that. And I think those two together are very powerful synergistic effects of just a reset, and to remind us all of what we already know, which is our natural state is a place of calm and a place of love and a place of peace. And once you experience that again, because it's very familiar, I think there's kind of no going back to the way that, to only handling things the way that we've kind of learned how to do it. Now, of course, those patterns are hardened depending on how long we've been using them. So that's where the integration comes into. It's not a magic pill or a magic mushroom or a magic toad or anything. It is, or magic root. It shows you, opens the door there, and then it's up to you to walk through and continue to walk, but it's very powerful, and it's had a lot of positive experience with a lot of people for what it's worth. So
I had two friends, close friends, that went through vets and SOCF and ended up down in Mexico and did the Ibogaine DMT, one of which had been on pain pills for over a decade, sustained just horrible musculoskeletal injuries while deployed. And this is back in the early GWAT when they were just handing out opiates like it was candy kind of thing. And the docs are being told one thing. If you watch the documentary on Netflix on opioid use and whatnot, the docs are being told this is good to go. Like, it's not addictive and blah, blah, blah. Anyway, they put them on a ton of meds, and just once you're on that high a dose, there's no just coming off. And he went down there and had no withdrawal symptoms right after doing Ibogaine, which is crazy. How is it you take this med and you don't have withdrawal symptoms anymore after being on some astronomical amount of oxys a day? And then I've heard the other one that I wanted to mention that I've heard really good things about is, and I know the founder, Jesse Gold, is Warrior Hearts Project, and they're doing, through their organization, they're doing some research on, I believe it's on psilocybin, but they also do ayahuasca. So he was going internationally. I think they still do. But then once Oregon has opened up in certain cities for psilocybin, they're doing psilocybin retreats. And that's another organization that's there. But I think that kind of concludes today's topic. Thank you for everybody who listened, and we'll see you on the next one.